This is Dr. Omar Almala. I'm going to be demonstrating a combined femto-phacoemulsification with posterior chamber intraocular lens implant combined with ab interno canaloplasty. As you can see here, the lens has already been softened using the Catalyst femto laser. The anterior capsular remnant is being removed here. Hydro dissection is performed just by placing the cannula just under the capsule and very gently irrigating. You can see the irrigation travel under the lens and loosen the lens. The lens is mobilized, and I use bowling technique, particularly with the femto laser. This is, I find it a very easy technique. You can see how far to go since the femto pretty much shows you where you are. Then with increased suction, I just bring the edge of the bowl in and just quickly aspirate it. Irrigation and aspiration proceeds in the usual fashion. Typically go underneath the anterior capsule and grasp the cortical remnant and just peel it off. I'm polishing the capsule here, and it was thoroughly polishing the anterior capsular remnant to remove as much cortical and epithelial cells as possible. This is a ring polisher. It's also referred to as the crystal lens polisher. I use it quite often to help supplement the cleaning and try to remove as many epithelial cells as possible. Here we're injecting a ZMBU. This is a Technis multifocal implant. The lens is rotated, centered. At this point, I'm using vancomycin to seal the incision. This will help maintain a better anterior chamber when we place the Zeiss gonial lens on top of the cornea for the canaloplasty. Here I'm making the stab incision, pointing it right where I anticipate making the otomy in the trabecular meshwork. This is the eye-track probe. It's been primed already. I'm inserting it and trying to place it approximately where I anticipate making the incision in the trabecular meshwork and into the canal of Schlemm. These are ring forceps that are very delicate. I usually use for trabeculectomies and handling conj. It works very well. This is a 25 gauge MVR blade. The gonial lens has been placed. I'm zooming in now to identify the structure of the angle. This is where keeping the anterior chamber slightly soft is quite helpful, because you can see some blood in the canal of Schlemm. That'll guide your position for where to make the incision or otomy into the trabecular meshwork and into the canal of Schlemm. The incision I'm making is about 2 millimeters. A side-to-side action, and usually I'll just depress it to make sure that I'm in the canal of Schlemm. Quite often blood will egress from the canal of Schlemm. In this case, the anterior chamber is slightly firmer, so no blood is coming out. And I will insert my intraocular forceps and very gently grasp the eye tract probe and guide it into the otomy that we just created. Once you're in the canal should advance very easily without any pressure. I just zoomed out a little bit so we can keep track of the tip of the probe in our peripheral field, visual field. You still have to concentrate on the intraocular part, but with your peripheral vision you can see where the probe is. I should have really irrigated that viscoelastic away from there so I could see the light coming around, but there it is right there. I can still see it. So we're almost there. Now the probe has been primed prior to passing it through. But once we get to our initial entry point, which is right there, it's quite important that you reprime the eye tract probe with Helon. I use Helon GV. Now we've turned the eye back to the primary position and we're looking straight down on the eye, and we're getting ready to pull the probe back. Now continuous movements, nice and smooth. Every 2 clock hours my nurse will click the Helon applicator, so we're injecting and dilating the canal of Schlemm. You must keep it moving, otherwise you can blow out the canal of Schlemm. And we're done with that portion. Here we are, I'm sealing the paracentesis tract, and we're just beginning with irrigation aspiration. It's very important to try to get all of the viscoelastic out as much as possible, because you have viscoelastic in the canal of Schlemm, so you're going to get a potential IOP spike from that. So you don't want any cortical material left in the eye that can worsen any IOP spike. I treat these patients with Diamox right at 500 milligrams sequels right after the procedure, and then also one more to take that night before they go to bed. That works quite well. Usually the next morning the pressures are somewhere between 10 and 15 by Goldman applanation. And we've completed this case. Thank you for watching. Hopefully this will be of help to you.